Now, you've mentioned you've got a palette of options out there that is expanding by the second, as far as I can tell. And the poor primary care doc has to keep up. What do you do about all that?
Well, you look at the pathophysiology and the treatments available, and the first step is pretty easy: diet and exercise plus metformin.
Okay.
And because metformin has stood the test of time, it's very affordable, it's easy to get, everyone has access to it. So that's relatively easy. The problem comes is when metformin is no longer working as the patient's disease has progressed, and that happens quite often, unfortunately. And then you have to consider, where's the patient at? There's no point adding on a therapy that lowers A1C by 0.5 if the patient's A1C is 9.5. You need to choose the appropriate therapy in terms of efficacy, in terms of risk of, do they have an erratic lifestyle and maybe at risk of hypoglycemia living alone? Or is cost an issue? Do they need to lose weight? I mean, these are all considerations.
Do they have heart disease? Do they have kidney disease?
Yes. Established heart disease, risk of heart failure. Do they have kidney disease? All these things come in.
So why doesn't somebody lay out for us a roadmap, if you will? What are right now the available non-insulin hypoglycemic agents?
Well, there's multiple options there. I mean, there are multiple options. In oral agents, you have sulfonylureas, you have glitazones, you have DPP-4, and you have SGLT2s, and other little ones that is not worth even mentioning. But and those are the choices. But one thing is going to happen in this day and age. In the end, formularies are going to decide what is in the formulary, what is being approved in the
Otherwise, you got to go prior auth, which is
and there has to be some priorities there. For sure, sulfonylurea is still being used because are extremely inexpensive, despite the fact that you give you weight gain and despite the fact that gives you hypoglycemia. And over time, you lose control. DPP-4s are being used widely, but they are expensive and they are not very robust in reductions. And we've seen studies that over time, you lose control. And then you have the SGLT2s. And with the evidence that we have that reduces cardiovascular events in people with cardiovascular disease, reduces weight, reduces blood pressure, I mean, I believe that yes, we made a big change when we said more aggressively lifestyle intervention plus metformin. I see the day very soon when the recommendation is going to be you start with a combination of metformin and SGLT2. Why to wait until metformin fails to add there? Because we're going to lose time. If I get diabetes, I will start with a metformin and an SGLT2.
Yes, but you're a rich man with good insurance.
No, I'm a Medicare guy.
My poor patients.
Why do I not believe this, man?
My poor patients who are restricted by formulary are often forced to take a sulfonylurea. And you know what? When I try to rationalize it, I think it's okay. It's provided they don't get hypoglycemia. If they do, I stop it immediately. And I talk to them about it when starting it. And they are effective for a period of time.
So Vivian, I actually I think that our patients, given the data that we've seen in the literature, would do better if we had cost as an issue to go directly to basal insulin.
Basal insulin requires a lot more testing.
It does.
And insulin has become quite expensive. And
you can use NPH insulin at Walmart. I mean, I'm just saying that we know if you put the sulfonylurea in that place for 2 years, by the time they're ready for insulin, you have a harder time getting there. They have greater weight gain and greater risk for hypoglycemia. Starting it early is a...
We'll get back to insulin. Insulin isn't going away.
No, and I'm an insulin guy for many years, and I was involved with the Treat to Target many years ago, and I believe that that insulin is there. I mean, there's no more quote-unquote natural intervention than insulin itself. If you lack insulin, you replace insulin. But one of the little things that you always did with people newly diagnosed, when you teach them to prick their fingers to check the blood sugar, we tell the medical assistants, give him a little shot of saline in the belly. And the patients will say, gosh, the finger prick hurts more than the injection. And we just tell them, you know, we're not going to start that. But eventually, soon, you know, we're probably going to use insulin in the future. We're going to give it some time. And that stigma of the injection goes away.
Okay. But again, we have non-insulin options, and you've all been talking about the generics of this, but let's get very specific. Tell me how you would sort of peel these layers off. Somebody's sitting in front of you. You want to start perhaps with a non-insulin option. How do you go about the decision-making process?
I agree with Julio that if you have somebody who's had a heart attack not long ago, is, you know, tired, maybe short of breath, they're at risk of heart failure, I would choose an SGLT2 inhibitor.
Okay.
But you wouldn't pick a thiazolidinedione. Just gives you some, I'm trying to give you some balance. There's things that you'll pick and there's things that you won't pick.
Let me give you one situation where you might pick a thiazolidinedione. There's the IRIS study showing a reduction in people who had a prior stroke. Very good outcomes.
Great.
So somebody has failed on metformin, they've had a
Perfect.
stroke, I would consider
But that's personalized medicine.
provided there's no contraindication. So again, you've got to go into indications, appropriate indications, and also contraindications of every one of these drugs.